السلام عليكم ورحمة الله وبركاته. معكم الصيدلاني علاء من شركة أسينو. أولا نحب نرحب بكم بحضراتكم جميعا ونشكركم على هذا الحضور إلى الويبينار العلمي، وإن شاء الله يكون ويبينار مفيد للجميع. كما نود أن ننتهز هذه الفرصة لتوجيه الشكر للدكتورة إيمان ودكتورة شغاف الأكيد غنيين عن التعريف لمشاركتهم لنا هذا الويبينار. دكتورة إيمان حتكون رئيسة الجلسة لهذا اليوم، ودكتورة شغاف سبيكر على لكتشر بسيطة عن الكونستيبيشن بالبريجننسي. ونود التنويه على فقرة انه فقرة الأسئلة والأجوبة راح تكون بنهاية كل محاضرة. والآن أترك المايك دكتورتنا دكتورة إيمان للبدء بهذا الويبينار. دكتورة إيمان المايك لحضرتك عيني.
Hello everyone and welcome to this webinar. I would like to thank all audience sharing us this webinar. Also, I thank Asino for sponsoring this one. It is an honor for me to moderate this webinar. Tonight, we will focus on an important subject in our daily practicing, which is constipation in pregnancy. You know all, it is a major problem during pregnancy and post-delivery, cesarean or normal. The prevalence rate of functional constipation in pregnant women is significantly higher than in general population, as you know. Some studies show that is also an educational issue. It's my pleasure and honor to introduce my colleague, Dr. Shagaf Dahan, a specialist in obstetric gynecology, art and IVF board consultant. Please, Dr. Shagaf, start.
السلام عليكم جميعا. مساء الخير. أتمنى أنكم تكونوا تسمعوني. Our subject today is about constipation and pregnancy. This is a common cesarean section, and I think it's an important topic to be discussed. Although it's not a very big complaint, but most of ladies are experiencing it. I'd like to say something about constipation. Constipation is a bowel movement that are infrequent or hard to pass. The stool is often hard and dry. Next slide. Next, please. So, from the definition, there are 4 criteria according to symptoms and diagnosis. The first one is training to evacuate. It contributes more than 25% of defecations, or the patient might have lumpy or hard stools, and it's also more than 25% of her defecations. Sensation of incomplete evacuation, more than 25% of defecation. Sensation of anorectal obstruction or blockage, as well more than 25% of defecations. And the manual maneuver to facilitate and empty her guts, defecation, more than 25% also. Less than 3 evacuations per week, yes. If any of these, the number of criteria for diagnosis should be equals or more than 2. The chronological factor is 3 to 6 months. That means the criteria fulfilled over the previous 3 months with symptoms onset at least 6 months prior for this diagnosis of constipation. This is in general. This will show how much is the incidence or the prevalence of constipation. It's frequently found sign during pregnancy, and up to between 11 to 40% of pregnant ladies will experience it at some stage of their pregnancy. And as we can see here, there are 2 studies, the Derbyshire and the Bradley. Derbyshire in orange and the Bradley in gray. We can see that constipation most frequently seen in the first trimester, with a sharp rise in the second trimester and decline in the third. And of course, we can see it in postpartum. It's a major issue for postpartum ladies. Next slide. Next, please. So in general, it's around, it's between 11 and 40% of pregnant ladies. This is a major issue during pregnancy, and this is a very good subject to be speaking about and to find solution for it. Next slide, please, Dr. Ala. Hello? Hello? Hello?
Next slide, Dr. Ala, please.
We were speaking about the prevalence of constipation during pregnancy. Hello? Okay, no slides. We'll speak about the pathophysiology of constipation. In general, it could be primary constipation that happens. Okay, this is the slide. So the causes of constipation in pregnancy, it could be hormonal due to progesterone, which is the major role, plays the major role in constipation or hypomotility of the bowel, and could be associated hypothyroidism. Could be, it could result from dehydration that results from nausea, vomiting, poor oral intake. It could be mechanical from the gravid uterus. Drugs like antiemetics, iron, tocolytics. It could result from parity, pre-existing diseases, chronic idiopathic constipation, irritable bowel syndrome, congenital or acquired megacolon, and chronic idiopathic intestinal pseudo-obstruction. But the major are the hormonal changes and the reduced exercise and reduced fluid intake and poor diet. So the presentation of patients could be to two categories. We can put them into two categories. The first one, the patients that has no history of bowel problems before, but they will develop the symptoms during for the first time during pregnancy. And the second category are constipation, those ladies that have constipation prior to pregnancy, but the symptoms can get worse during pregnancy. Next slide. So, particularly constipation that may follow surgery. It could be due to many reasons. The first one is the general anesthesia, the reduced food and water intake before surgery or after surgery shortly. Nerve damage during surgery could be an attributable factor. Medications, especially opioids, that are taken by the patient for the pain relief. Lack of physical activity, that's staying in bed for a long time. That's why we encourage ladies to have early mobility after delivery or after surgery. Dietary factors, these are the most important, that they have low-fat diet. Constipation already present. They might be already constipated before surgery, and this will get worse post-operatively. Then the last cause, it may be ignoring the urge because of the pain at the site of operation, pain at the site of episiotomy, pain at the site of cesarean section. Then, what is most important, that we have to educate our patients about the healthy habits to reduce constipation. This is our role in educating our patients. They could be well educated from their mothers, from their family, friends, but most of them, they don't know that simple issues may break and may feel them relieved from constipation. And these are the most important. This is the eating high fiber diet, drinking a lot of fluids, water, juice, whatever. Exercise moderately, routinely, daily, they should exercise. And last but not the least is their iron uptake should be reduced or eliminated. But sometimes they are asking for iron supplements all the time. And this iron supplement can cause them constipation, so we can change the iron. We can use ferrous instead of ferrous sulfate, ferrous fumarate, or ferrous glutamate. These will, in some ladies, it will ease their constipation. Okay, next slide. This is a very good slide for showing what are the percentage of women exercising and which type of physical activity they are offered. The first and most important is walking. You can see in yellow color, these are the pregnant, and in the orange are the non-pregnant ladies. You can see walking, even among pregnant ladies, this is very important, daily exercising. They can do aerobic exercises, but not the strong one. They can go for swimming. It's very important. It will give very good body shape. Gardening, if they have gardens, it gives positive energy and as well as good body exercising. Running or jogging. This is not for our ladies. Cycling, bicycling is very good in exercise, weightlifting and home exercise. Most of our ladies, if we do this study on our ladies, we can see that home exercise is the number one. Now, a very important note to notify here is that the most important note to be declared to our patients that too much calcium can cause constipation, particularly dairy products. This is to emphasize that calcium can cause constipation. What are the foods that we anticipate that they will cause constipation? The first one is gluten-rich foods. Too much gluten can mean too much tough fiber, which means refined grain. Hello? Yes. Okay. Sorry for this interruption. Refined grains, dietary fibers stripped out of the grain when they are processed and refined. And this will lead also to decrease the bulk of stool and will end up in constipation. Dairy products, as we mentioned, fried foods. This is very important because now it is fried, delicious, but they don't know that this will end up in constipation because of the saturated fat and salt content on fried foods could be causing your constipation. And at last, for some ladies, alcohol can dehydrate you and your stool and will result up in constipation. This another slide, please. So, what to do? The best advice to start with combating constipation is to increase dietary fluid intake, to increase fiber intake, and moderate exercise. If this was enough and there was improvements in symptoms, that's it. This is a simple advice and the patient will end up with no problem in her bowel motion. But if this was not enough, what to do? If there was no improvement, then we should offer laxatives. Then we add or switch to one of the following. First one is bulk forming agents such as bran, aspergilla, methylcellulose, stercula. Osmotic laxatives such as lactulose, polyethylene glycol, and sorbitol. The third category is stimulant laxatives such as bisacodyl and cinna. And the last is suppositories, are suppositories such as glycerol suppositories. Next slide. Next, please. The pathophysiology of constipation, the types of constipation in general are either primary or secondary. The primary, that result from no underlying contributing factor. This is primary in their bowel, while the secondary result from either pharmacokinetics, pharmacotherapy, or medical conditions such as gastrointestinal tract problems such as anal fissure, hemorrhoids, colorectal strictures, and neoplasia, or could be metabolic disturbances such as hypothyroidism or hypercalcemia. Other factors could be neurological disorders such as irritable bowel syndromes that are associated with constipation, and this is we can see it in a lot of patients. The other slide, please. Okay. In pregnancy, in particular, the changes in hormonal levels in pregnancy are the main factor that cause constipation. And the main hormone that causes constipation or can contribute to constipation is progesterone level. This will lead to intestinal smooth muscle, reduced motility. We have another hormone. This is the motiline, which is a peptide hormone, stimulates smooth muscle motility. This is usual. It stimulates smooth muscle motility. This is inhibited by the rise in serum progesterone and somatostatin, which is normal physiology of pregnancy. And we have another hormone which exhibits inhibitory effect as on the bowel, which is relaxin. And this acts on the myometrium and appears to contribute to intestinal hypomotility. During pregnancy, there is an increase in water absorption due to the activation of renin-angiotensin system. And this will result in high levels of circulating estrogen and progesterone, which stimulate renin secretion and aldosterone production. Aldosterone, in its role, it will stimulate sodium and water reabsorption from the gut as well as from the renal tract. And this, the next slide, please, will reduce the water intake content and will result eventually to harden the stool. And this is the major problem, and this is the major physiology of constipation during pregnancy. So starting with progesterone, and which will end up with constipation. Constipation will result in hemorrhoids, anal fissures, and anorectal problems and pain. And this will result in a visuous circle. That's we have pain during defecation resulting from constipation, and this pain sometimes will end up with hemorrhoid or fissure. And this will result in pain, and pain will result, this will give visuous circle. So the most important, we should combat constipation with the medications that will be shown. Now, the current medical treatment options for constipation. The first group are the bulk forming agents, such as bran. This will absorb water to increase fecal mass, which then stimulate intestinal motility. The bulk forming agents are not systemically absorbed or linked with increased risk of malformations. They are safe for long-term use during pregnancy. This is important. However, they are not always effective and might be associated with unpleasant side effects such as gas ballottement and cramping. They have slow onset of action and requires increased fluid intake. Always we advise patients to have excess fluid when they take them. The second category are stimulant laxatives. Bisacodyl and cinna increase intestinal motility by stimulation of colonic nerves. They also reduce water absorption from large intestine. They can be used for short term during pregnancy. However, women might also experience unpleasant side effects such as abdominal cramps with the use of stimulant laxatives. Stimulant laxatives should be used with caution in the third trimester, as they can stimulate uterine contraction. They may induce premature labor. Chronic use of stimulant laxative can cause irreversible damage to myenteric neurons and laxative dependency. This will end up with lazy colon. Therefore, their use is limited to acute constipation and pregnancy. Other category, next slide. Next slide, please. Dr. Ala? Okay, osmotic laxatives. They draw fluid and electrolyte from the body into the gut by osmosis, which bulks and softens the stool. So example are magnesium sulfate, lactulose, sorbitol, macrogol. In general, osmotic laxatives are poorly absorbed systemically. This is good for the pregnant lady. However, individuals might experience also some side effects such as flatulence and bloating. The prolonged use of some osmotic laxatives, especially magnesium sulfate or lactulose, might lead to electrolyte imbalance, and this is serious during pregnancy. Should be avoided only for resistant cases. The combination, we have combination of bulk-forming agents and the stimulants, such as the Ediolax. Some products contain combination of bulk-forming agents and stimulant laxatives. The ingredients are psyllium, C, senna, fruit, tinnivelli. Since it contains stimulant laxative, senna, it can only be used for short period to avoid lazy colon. So, what to do? Other slide, please. Dr. Ala. Next.
It takes 2 seconds to reach you, Shiraz.
Okay. So, the combination of bulk-forming agents and stimulants, we should keep in mind for this group that each 5 gram, which is 1 teaspoonful, contains 1.04 gram of sucrose, 20%. Should be used in caution with patients with gestational diabetes or who are already diabetic during pregnancy or known cases of diabetes. Because of genotoxic risk of several anthracoids, example, imodium, imodine and alloimodine, the use should be avoided during the first trimester. So these should be kept last of the list. Okay, next slide. That means we should not use them for diabetic patients and they should be avoided to be used during the first trimester. Next. Next slide, please. I think I should speak about, I should tell something about home message that for each pregnant lady, we should alert her for the possibility of constipation during her constipation. Yes. Hello? So the home message is increase fluid intake, increase fiber in diet, and moderate exercise. But if these all they don't get benefit from these, patients should go for medication. The other type of lubricant laxatives are the mineral oils. Mineral oil decreases stool surface tension and they will lead to increasing water penetration. Increased water penetration. Mineral oil is poorly absorbed from the gastrointestinal tract. However, its use during pregnancy is contraindicated as its use can cause hemorrhagic disease in the newborn due to impaired absorption of vitamin K. This is very important. Okay, next slide. The American Gastroenterological Association Institute, they would recommend on the use of gastrointestinal medications in pregnancy. They stress on that polyethylene glycol is considered low-risk treatment, and it is the preferred treatment for chronic constipation in pregnancy. Next slide, please. So, in some the drugs that are can be used. Okay, this is the home message I was talking to you about. We should alert the pregnant ladies about constipation, encourage her for increasing her diet rich in fiber with simple exercise, not to forget that lemon is great for digestion, and we advise her for drinking plenty of water, warm water, especially in the morning, consumption of teaspoonful of olive oil in the morning on an empty stomach. This will ease her bowel motion. Although many laxatives are available, it's important to check which one is safe for you. Thank you.
Thank you, Dr.
If there are any questions,
for this
most welcome.
Okay. Thank you, Dr. Shigab, for this nice presentation and information. Please, any question from the audience? We can start. You have minutes, please. It's a very important subject, as we mentioned.
Yeah. Yes, it's indeed very important. And our poor patients, they are not complaining. They can take it as constipation and that's it. But we can help them to solve this problem with simple laxative.
Yeah. I have a question for you, Dr. Shigab.
Yes, please.
About what is your recommendation after delivery for women complain from constipation? That means she's past the pregnancy.
Okay. This is a beautiful question. Thank you for asking it. It depends on whether the patient delivered normally or cesarean section. For both categories, we should encourage plenty of water intake. We should encourage her for early mobilization, because early mobilization will enhance the bowel motion. And if any pain at the site of surgery, we should give her some analgesic. Don't give extra opioids, because this will increase constipation, extra fluid. Also, I mentioned that diet rich in fiber is very important and vital for relieving constipation. And if these all, they don't result in better bowel motion, we should encourage her for taking laxatives. And as we say that polyethylene are the safe during pregnancy and post-pregnancy also, after she delivers, whether normal or by cesarean section. And if the patient, this is an important message to be told to the patient, if the patient got chronic constipation and she was not relieved after delivery, she should consult eradicate or to exclude any pathology, pre-existing pathology. I hope this answers your question, Dr. Iman.
Thank you very much. Any question after the next lecture? So any question, please? Dr. Ala, Dr. Shigab, anyone from the audience?
Thank you for this informative lecture from Dr. Hussam.
Thank you.
I think now we are satisfied, and our
Yes.
patients will end up with no constipation. They will have normal bowel motion.
And safe, and also safe is the most important thing.
Safe. This is most important. Yes, thank you. Thank you for this supplement. Okay, thank you.
Okay, at the end of this interesting webinar, we thanks all audience joining us. We hope we reach the goal about the management of constipation in pregnancy and post-delivery. And deepest thanks, of course, to Asino. They are always keep up with update information with us. Thank you again and have a good night. Thank you very much. Thank you.
Thank you.
Thank you.
For all.
Thank
Thank
you.